Great. If everybody can take their seats, we're ready to go. Is the mic on? Great. Okay. For the last stragglers, we're ready to go, and I would like to greet everybody and welcome you to the WHO Hub for Pandemic and Epidemic Intelligence here in Berlin. My name is Sarah Hersey. I was a member of the Hub until about 2 weeks ago, but I'm very excited to be back here. I am now actually in WHO Geneva, where I lead pandemic strategy and partnerships for the Health Emergencies Program. But this is my true home, so very glad to be back here. Tonight, we are co-hosting this event with Charité. I'm very happy to have them with us, and I'm very excited because this is a theme very close to my heart. What we're going to be talking about tonight is strengthening emergency preparedness and response capabilities for national public health agencies. And this is something that we've been working towards with many people in this room for months, if not years. So we're excited to be taking this forward and having all of you with us. In the audience, I'd like to greet, and we're very honored to be joined by two esteemed guests, our ambassador from Republic of Zimbabwe, as well as the ambassador from the Kingdom of Lesotho. So thank you very much. We really appreciate your support to this work. We also, yes. We also have our partners in the German government with us, diplomatic missions, academic institutions, international organizations, civil society, and private sector. So as always, we get a good cross-section of people that don't necessarily always engage with WHO or with each other. So we really look forward to these opportunities. We also are live streaming on YouTube. We have over 50 countries joining us right now. So they'll be participating, and this will also be posted on our YouTube channel for posterity. So you can always go back and watch it again should you like. For those who are in the room, you have this on your seat. There's a QR code on it. So when we get to the panel discussion later, you can submit your questions through the QR code. For those of you who are online, there is the option of submitting questions through the online platform. So please do take advantage of that. It will be after we do several presentations when we get to the panel discussion. So just to set a little bit the scene for what we're going to be talking tonight, I think as most of you know, WHO is a global public health organization, and we can't deliver on our responsibilities, one of them, which is emergency preparedness and response, unless we have the tools and resources to successfully do so. And technical capacity is critical, and most people know WHO for our technical capacity, but equally critical are the foundational elements that support this work. So these are regulations, these are authorities, these are staffing and financing. The boring stuff have to be in place to realize our mandates. And the national and the regional agencies, our sister agencies, are no different. They really need to have all of these pieces in place to be able to deliver on their responsibilities and their mandates for emergency preparedness and response. So in order to support them, WHO consulted with our regional and our country level agencies to ask them, what is it that you need that we can do to help better support you? What is your mission in emergency preparedness and response? And overwhelmingly, what we were asked is for what we are going to be talking to you about tonight, is this capabilities framework for what do we need to have in-house for our capacities to deliver on emergency preparedness and response. And so you don't have them on your seat because we don't have enough right now, but this is the report that we're launching tonight. We're very excited. We will have some available after the presentations. So I would like now actually, let me talk a little bit more about the framework. So the framework itself was developed by WHO with our colleagues at IANPHI, which is the International Association of National Public Health Agencies or Institutes, and they're going to have a chance to talk to you tonight. And we consulted with over 120 countries and organizations. So we are going to talk a little bit with WHO tonight, but we're really going to have our partners and the countries lead the conversation. So we're going to have IANPHI speaking, we're going to have our regional partners, we're going to have some of our country partners speaking. And so we're really looking forward to that. So now I'm going to turn it over to our co-host, Professor Stephen Flasch he's a professor of infectious disease and global health for Charité University. So please, Stefan.
We practiced this.
Oh.
It's okay. I think this works. Good evening, everyone. Exactly. Good evening, everyone. It's a pleasure for me, on behalf of the Center for Global Health at the Charité, to welcome you all today. And that's particularly for all the guests you don't see around you and those who are seeing us in 2D from the screens, but of course also to all of you who made your way to Berlin today and who were able to make your way. And thanks to Sarah for the introduction and for setting the scene so nicely. And thanks to the colleagues of the WHO Hub, both those who are in the room with us today and those who work tirelessly behind the scenes in a great collaboration in setting this speaker series up and making it the success that it is. So as a co-host, the Center is very pleased to have supported the speaker series for quite a while now. I think we're in the 13th iteration now. And it's really nice to have it see mature over the time and to become engaging for a wide audience, both those who happen to be in Berlin and abroad. And the speaker series has done a really tremendous job in bringing together multiple stakeholders. We have ambassadors here in the room, but also bridges to academia, public health institutes, and other global partners in the joint challenge that is pandemic preparedness. And so the theme of the session, strengthening emergency preparedness and response capacities for national health agencies, couldn't be really more timely. Because it's only really the inter-pandemic period where we have the opportunity to think about those things, which is, well, contrary to our own intrinsic motivation to think about these things when they're actually happening. So now is really the time to think about this. And so we've seen a lot of progress over the last, well, many years in the preparedness, both on, well, how we generate data, how we interpret data, how we use analytical, quite complex analytical frameworks to analyze data in real time. And I'm thinking, for example, of, well, enhanced use of wastewater surveillance or real-time genomic analysis or other complex mechanisms to track and understand the pandemics as they evolve in real time. But also, the COVID pandemic has taught us some valuable lessons that good data and good evidence generation more generally doesn't necessarily lead into automatically the best decisions being made. And so this is in part what we need to work on. And so from our own perspective at the Center for Global Health at the Charité, a lot of what we're doing is in very close proximity to policy, and most of the projects we're embarking on have a clear policy perspective in mind. But as well, many of you are aware, that doesn't always work out because of the nature of the policy process, which is typically coming with quite strong time constraints, particularly in a pandemic, has to be making decision in real time on partial evidence and support optimal evidence. And so in order to strengthen that process, we need strong partnership and strong institutions, which we can only build in this interpandemic process. And so the national public health agencies are an absolute essential part of that process, because this is where all comes together. And this is where the evidence is in part generated, in part reviewed, and where it has to be translated into policy options. And so from an academic point of view, which, well, is my personal one, the role is also to work in partnership with the public health agencies to ensure that understanding, that common language is developed so that we can then use it when we need it in an emergency. And so that all together is highlighting the importance of strong partnerships across multiple sectors in order to then move from insight to impact in a meaningful fashion. So with this, I also would want to welcome our speakers that are joining us today, as well as our panelists that you will be seeing in a minute. and hand back over to Sarah for the introductions. Thank you.
It's got to go back down. It's fine. Thank you. Thank you so much, Stefan. I think what you might have done without realizing it is you said the motto of the Berlin Hub, which is better data, better analytics, and better decision making. And so I really appreciate that this is really the arc of what we were designed to do, and this leads perfectly into the fact that the decision making does not happen without the national public health agencies and the partners on the ground as the true decision makers, the policy makers, and the people that are moving emergency preparedness and response forward. So with that, I'm very happy to introduce the big boss. And I will just say, I said that I've just recently left Berlin, but I had my first speaker series exactly 3 years ago. I did my first moderation, and I mispronounced my boss's name. So I have practiced quite a few times since then, and we're gonna do it right this time. And then I'm gonna remind him during my performance review that I got it right. So I am very, very pleased to introduce Dr. Chikwe Ihikwazu, who is the Executive Director of the WHO Health Emergencies Program, where he leads preparedness for and response to health emergencies, including disease outbreaks and humanitarian crises. Over to you, Chikwe.
Thanks, Sarah. You definitely got a few bonus points for that. But firstly, just to say, welcome colleagues to the Hub. I still feel I should welcome you. And thanks for joining in Berlin and online, wherever you are. And it's a very, very special day for me, actually. And I'm really sorry that I can't be with you. I would really have loved to, but I have to. I can't let go of my responsibilities in Geneva this week, sitting with a group of colleagues negotiating the new pandemic PAPS annex, the Pathogen Access and Benefit Sharing Annex of the Pandemic Agreement. And I hope that we can pull off one of the most consequential events in public health at the World Health Assembly in May this year. And so, but before we do that, we have a lot of negotiations to do, and that's what we're doing in Geneva this week. But really, for today, thanks a lot to our colleagues, our friends, partners in Charité for sticking with us as we've delivered on this speaker series, but also to IANPHI, the Robert Koch Institute, and literally national public health agencies from around the world that are joining us in Berlin and online today. You are the reason we're here and the driving force behind this, because today really marks an important milestone, the launch of the WHO framework for emergency preparedness and response capabilities of national public health agencies. And you know, COVID-19 really exposed gaps in our global preparedness at all levels, but especially at the national level. And we enforced why we absolutely need strong national public health agencies. And it is not a surprise that since the pandemic, more and more countries have set up new agencies because the gap that we've been talking about for ages has become apparent to everyone. And of course, I had some first-hand experience of this gap, leading the response in Nigeria and trying to figure out all sorts of things in the middle of the pandemic, because there was simply no playbook. We had nothing to refer to, no reference material, and nothing that could bring it all together. And so we were figuring it out and making it up as we went along. And this wasn't just at the national level. Together with John Nkengasong, who was also the first director of Africa CDC, figuring it out at the regional level. Globally, I was privileged to be a part of a small group of leaders, mostly heads of national public health agencies around the world that were convened by Dr. Tedros at the time to support him, both to feed up information in terms of what was happening in our countries, but also filter down advice from him and from each other on what to do. So there was simply no playbook at the time of an unprecedented crisis. And so we all figured it out, and then we wrote about it. And I'll do some shameless advertising because when I finished, I wrote about my experience during the pandemic leading NCDC. And if you leave aside the title, An Imperfect Storm, the most important one is the subtitle, A Pandemic and the Coming of Age of a Nigerian Institution. Because at the heart of this book was really writing about what the institution learned and what we learned. But throughout writing the book, I also realized that, why are we learning all this stuff ourselves? Why don't we have the reference materials consolidated in a single place that we can refer to? And so post-pandemic, there have been lots of so-called post-COVID initiatives. The one you're sitting in Berlin is one of them. We're very proud of the hub and what they've become. And there are many more. There's the BioHub, there's the Pandemic Fund. They're all sorts of global institutions that have grown out of the pandemic, and rightly so, we're proud of all of them. But ultimately, the responsibilities always start locally. They always start in a local outbreak, a local emergency response, and somebody has to be responsible at the national level because the world is organized in countries, in sovereign states. And it is that sovereign state that has the responsibility to define the response to the threats that it faces. Now, who does it delegate that responsibility to? Has to be an institution with both the delegated responsibility and the resources and the accountability mechanisms to do this. And so most countries are coming to that realization that strong national leadership and accountability are foundational to whatever we do globally. So they're foundational to global health security. And we have to work on building a framework for this accountability to work. So our collective responsibility is to capture those lessons, and put it together into a framework that we can use. So member states, pressure came from many countries around the world asking WHO, we are all in the process of setting up new national public health agencies, or we are changing the laws around the ones that we have. Please, can you guide us on what to do? Offer us some guidance on how we set up these new institutions. And it wasn't a good place to be for us, not being able to offer countries guidance on these institutions that they thought that they needed and had assumed that we would have guidance on. And there's nothing I would have desired more than in July 2016, when I was appointed to NCDC, that I had this framework that we're launching today, that there was something I could look at and see what are the functions, capabilities that we should build in this new institution and to guide us in the building process that we are about to embark on. We didn't have it at the time, for sure, but we have it today. And that's really what is the background to this document. It's gone through the consultation and you'll hear about it, but really proud that after 2 years of asking countries what they needed, asking experts what they needed, learning from each country's experience across the world, north, south, lower, middle, and high-income countries, we finally have a document that every new leader, every staff member, any aspiring young public health colleague can take in and look and have a consensus view of how new national public health agencies should be built and what they should do for the people that they serve. So I'm really proud that we have this framework today, and you'll hear a little bit more about it. It provides guidance to countries to do exactly what I've said, find their own path, navigate that journey, and put together these capabilities. It offers countries a practical tool to change their aspirations, ideas into something concrete, and take it back to their government and say, listen, this is WHO's guidance on how we should do this. I don't need to figure it out myself. I don't need to think to myself on where what should be, on what level of resources I need, on how to structure my surveillance system. Should I have an EOC as part of my NPHA? These are questions that this framework helps us to answer. And I hope that in the discussions today, you will see not only why it's important, but how it delivers on its promise. So let me conclude by saying our work is not done. We have a beautiful document that we've spent 2 years in developing, but it doesn't belong to the world. It doesn't belong to WHO, it belongs to the world. It will evolve with time. It will become eventually a living guideline that we can adapt as we learn new things, as new capabilities and new resources become available. We are proud of the relationship and work with IANPHI, the International Association of National Public Health Institutes, because it is that network that we serve primarily in terms of the institutions that we're building. And we look forward to working with everyone in the room, all those watching online today and in the future, to shape the work we do in these institutions. And I hope that this framework leads us to the future that we are going to create together. So Sarah, let me pass it back to you. Thanks a lot, everyone, for attending. I look forward to the conversations ahead of us. And most critically, I look forward to the feedback from the leaders of national public health agencies around the world, for whom this new framework hopefully will be a guiding light to the work that you do for the people that we serve. Thank you very much. Thank you.
Thank you so much, Chikwe. Always very difficult to follow Chikwe, particularly when he's so passionate about this. So I am going to turn it directly over to my colleague, Geoffrey Namara, who is going to take us through some of the details of what this NPHA framework looks like and how it was developed. So Geoffrey, please kind of come up here.
Thanks very much, Sarah, and thanks to Chikwe. So over the next few minutes, colleagues, I will share with you the process, the content, and what we do thereafter. As Sarah did mention, I've had the honor of leading the day-to-day operational processes for the development of this framework over the last 2 or so years. So colleagues, this framework that we are launching here today is a culmination of loads of global expertise consultations. It's a product of multi-phase approaches and rigorous methods. We started this with a very extensive process of literature review and the available research on public health agencies, both the normative guidance work, the academic publications, what other regional entities had established, and came up with a draft. And this was about 1.5 years ago. And following that draft, we now started doing loads of consultations from each of the regions, beginning with the Eastern Mediterranean region, all through to the others. And at the end of each regional consultation, which brought together public health experts from the different countries, NPHAs, partners in the region, they looked through, gave us feedback, and then had an iteration, developed another version, took it to the next region, got feedback, some of which undid the previous comments and things like that. At the end, we have what we think is a document that brings together input from the entire expertise. This has had input from more than 120 member states, including 45 public health agencies. So the document is essentially broken into 3 chapters. The first one is highlighting the diversity of emergency preparedness and response. Then the second 2, which are the priority ones, break down these capabilities. We have them in 2 domains, foundational capabilities and technical capabilities. The foundational capabilities, which as the name suggests, form the bedrock of any effective emergency preparedness and response system, and these relate to legal authority, the institution or the agency being able to generate the evidence and guidelines for emergency preparedness and response policy, and then financing for that institution. Next to that, we have the technical capabilities, which have been grouped along the WHO Health Emergency Preparedness, Response and Resilience Framework, or the HEPA framework, that has the 5 core elements of emergency coordination, collaborative surveillance, safe and scalable care, community protection, and access to countermeasures. So these 9 technical capabilities cut across these areas. I will not go in detail to mention each one of them, but they all are aimed to be aligned to the other existing documents, complement them, and help you pick out your particular capability of interest and read more into it. Taking an example of the 7th capability, which is public health surveillance, intelligence, and analytics, a capability that most of the national public health agencies tend to have the mandate for. The way the capabilities are laid down is we state the capability, highlight some of the key sub-capabilities. It may not be fully exhaustive, but we've made a significant attempt in doing that, making sure we capture all. And then underneath each, we highlight key resources. If, for example, for surveillance, delivering timely integrated disease surveillance, how do you do that? We provide the resources, which could be partner documents, WHO normative guidance documents, all to achieve the desired outcome of having public health intelligence that will be vital in informing evidence-based decisions. This framework acknowledges the diversity of public health agencies. We are not saying they are all the same. They are very diverse, and there isn't this one model of all fitting into. The diversity is largely from the research we've done around the level of autonomy from the parent organization or the breadth of the mandate or the EPR mandate that they do have. And so the framework is designed to be very flexible and one that can be adapted to each country's unique institutional arrangements. So, in conclusion, how do we then take it on from here? We've launched the document. You've had many of others, and some are actually out there. You can pick a copy for the few that are available. How do we then take it on? One is we need to make that decision. It all starts from the country making that leadership, political, technical decision or commitment that we are going to either establish our institution or we're going to restructure the institution, or basically we're going to make that decision. And following that, we propose that there has to be a multi-sectoral convening, not just health, not just infectious diseases, but broader, that bring together the different stakeholders and then map the EPR ecosystem. Where does each of these EPR functions lie at the moment? Who leads? Who supports? And then from these, we prioritize to, depending on your unique context as a country, which one can we which of these different 12 capabilities do we want to take on first? Because it's going to be, this progress will always be incremental and continuous. Even the very mature NPHAs are still on that journey, including as well as the ones that have just been established. And following that process, then the case for investment, put together the required resources to make that happen. So in conclusion, this has been a truly, truly global collaborative effort, and we want to thank the different stakeholders, beginning with the member states that provided us this feedback, the partners that have been walking this journey with us internally, the different WHO groupings, regional headquarters, country offices, but special thanks to our partners, IANPHI, the Robert Koch Institute, the consultants that have been on this work, Ata Health Strategies, and this certainly would not have been possible without the generous funding of the German Federal Ministry of Health. With that, feel free to scan the QR codes. There are others also out there that you can pick the e-copy from. Thank you.
Thanks, Joffrey. For those who didn't capture the QR code, we will put it up after the session, and you'll have time to do that. So I think you've heard enough from WHO, and now we're happy to turn this back to our partners. We've talked quite a lot about our partnership with IANPHI, so we're very happy to invite them to the stage. In particular, Dr. Neil Squires, who's the Secretary General of IANPHI. He was appointed as the Secretary General in May 2025, following a number of senior roles in the United Kingdom, Africa, and Asia, including Director General of Global Operations at the UK Health Security Agency and the Director of Global Health at Public Health England. So please, Neil, happy to have you.
Thank you, and it's a pleasure to be here and to cement that really strong partnership between national public health institutes and the World Health Organization, and particularly the team in the Berlin hub here. It really has become a friendship that carries this work forward. So if we, well, I've got the control here myself. A little bit about IANPHI, first of all. We're a network of national public health institutes. These are the organisations at a national level who coordinate the delivery of essential public health functions. Often part of a ministry, but we like to have a level of independence because it's important that evidence and science informs policy and action. And we've seen a lot in the world now with politics shaping the health response, and that can be dangerous. We need a level of independence so that we have trust from our communities, so that the communities know that the scientific advice that informs the public health response comes from reliable sources. And WHO has that credibility, and national public health institutes need to have that credibility too. So whilst we were formally launched, I'm just trying to click this. In 2007, we've been functioning for 20 years. We've grown tremendously, and there is significant capability. Chikwe mentioned the importance of, the challenge he faced, sort of trying to cope with a pandemic, not knowing there was no guidebook. One of the things you need in times of crisis are friends, people you can rely on. And again, whilst you can make friends in the midst of a crisis, friends that you trust need to be built over a longer period of time. And so we need to build that trust between the leaders of national public health institutions who can rely upon each other in times of crisis. And that trust is built up through regular exchange between the leaders, the network of chief executives of those organisations, but also between the teams that they run. And they need to be able to exchange information rapidly when they need and when there's a demand for it, to phone a friend. So we all need to be able to phone a friend in times of a crisis. And what we hope IANPHI does is provide that important phone a friend function. And that trust extends to their teams, where senior leaders leading the laboratory's response and sharing data need to rapidly exchange information. We saw this during COVID with lots of rapid exchange of information to help shape the response, and it's a critically important function. So we're just in the process of developing a new strategy. Our function really is to build that national public health institutional capability. We need to strengthen the links between organisation, but also draw upon that huge capability that exists in that global network of national public health institutions. So the strength comes from that collective capability. And this is a prime example of global solidarity, where we all know and trust our partners working in the public health field, and we can depend on each other, share information rapidly. But if we're going to do that effectively, we need to have a common language. And that's where the framework that WHO has developed is critically important. It's providing those key structures, that common understanding of the forms and structures that can best respond to crises, so that we all have that common picture and we all speak the same language. One of the broader focuses of IANPHI is to deal with the essential public health functions. So we've worked closely with WHO to define this set of essential public health functions. Emergency response is a section of that essential public health functions. But we know that during the pandemic, the people who suffered most were the elderly, people with comorbidities. So we can't only deal with emergencies as part of the public health response. We need to understand the inequalities, the poverty that lead to illness and comorbidities that leads to vulnerability. And therefore, we want strong national public health institutes that can deal with the full range of essential public health functions. And they will then be capable of responding effectively to emergencies when they occur. So this broader range of functions is there. And this is why, in addition to IANPHI's framework, the WHO framework, we have an IANPHI framework which talks about that broader set of competencies and capabilities. And that is sort of working with key partners in order to deliver those functions. So in addition to the framework, we have a code of practice and a whole set of tools that can support countries. One of our key operating tools is a stage development tool, which relies on countries assessing their own capability, developing their own vision of what they can achieve with their own resources. And therefore, it's important to link the WHO framework for emergency response to that dialogue that needs to occur in every country to understand national capability, national assets and resources, and how they can be most effectively deployed to achieve major impact. And that combination, that work between WHO and IANPHI is that opportunity to be informed by what national public health institutions are doing in every country, to draw on a common framework to have increasing standardization of approaches, and to share lessons and good practice between countries so that we don't all make the same mistakes. We can learn from others' challenges, and then we can phone a friend when we're struggling with particular difficulties. So there's a whole set of core functions. I'm not going to go into the detail of this, but there is detail that interested NPHAs can look at and decide which of the functions that they will provide. There are some national public health institutions that deal only with emergencies, but we also have members who deal with health promotion and non-communicable diseases. And all of that functional capability has a role in emergency preparedness and pandemic response, because we need to ensure those critical functions are maintained. So as this global network, we meet on an annual basis to reinforce those peer-to-peer connections, that personal connection. Systems don't function without people. People need to be connected. And in a time of an increasingly fragmented world, having a network of trusted partners that you can turn to is critically important. Having strong national capability and resilience is also critically important. We've learnt, and many low and middle income countries have learnt, that they can't rely on the external world all the time. They need and they have assets of their own, and mobilising those assets in the most effective way with strong technical guidance from documents such as this of WHO is critically important. So this is a partnership that was, for me, made in heaven, and I really want to thank WHO for everything they've done in order to sort of, make this real, and the fantastic leadership that's been shown by the WHO Hub. So thank you very much.
Thanks so much, Neil. I haven't often heard heaven and WHO used in the same sentence, but we'll take it. Thank you very much. And also, I think for bringing us back to and highlighting the importance of trust. I think everybody in this room understood when we were combating the COVID pandemic, the importance of trust between family and communities and with your own government, but really very important also, and sometimes is missed, the trust building between institutions and between countries is extremely important. So these types of guidelines, as Joffrey said, the level of consultation that we did also built a lot of trust between the countries that came together and debated. I mean, this was not necessarily very straightforward. We had a lot of different opinions, and it got the opinions out. And that's a really, really healthy way of building trust. So I think a secondary piece of importance from doing this. So now we're going to turn to our regional and our country partners, which we're really excited about. And we're going to hear from 3 speakers who are going to provide their experiences nationally, regionally, and globally on how they're translating these frameworks into concrete real life impact in their daily work. So it's not just a piece of paper. And then we're going to have a chance to ask questions to them from a panel. So I'm very happy to introduce our first speaker, and I hope she's with us online, Dr. Kamene Kimenye, and she is the Acting Director General of Kenya's newly established National Public Health Institute and the chairperson of the Regional Technical Advisory Committee for the Africa CDC. She's also held a number of prior leadership roles in Kenya's Ministry of Health, and we're very excited to have her with us today. So over to you.
Yeah, thank you very much. It's an honor for me to be in this meeting today. I'm glad to present the Kenyan experience in emergency preparedness and response, looking at capabilities of the country. And next slide, please. So globally, of course, we have noted there's been an increase in frequency and complexity of multi-hazard threats, this including outbreaks, climate-related disasters, humanitarian crises. And of course, we have had persistent gaps in core capacities as observed under international health regulations. The World Health Organization, of course, has done some assessments, and these ones have also shown many countries remain unprepared for detection, response, and recovery. Kenya's joint external evaluation, for example, identified both progress and critical gaps in preparedness and response. And now, with all this, it is time for creates the need to shift from reactive response to a proactive preparedness. Next slide. So as many countries have considered establishing NPHAs, it has been critical, as you can see from the Africa region. We have 80% of member states have NPHAs at different stages of development. And this, of course, has been very crucial. And countries are trying to solve one of the most important problems, ensuring that we have coordinated public health functions under one roof. And this is important to reduce fragmentation of functions. In most countries, you'll realize surveillance, emergency response, and others are in different, maybe even different ministries, different state corporations. And of course, this leads to wastage of resources. There is also delay in response in most countries. So I think having member states develop NPHAs has been very good. And we are also thinking that it's important for us to advocate for the place of these institutions in the member states. The different countries most likely will also talk about the challenges they face in establishing their institutions. Next slide, please. So the Kenya Institute, Public Health Institute, was established under the State Corporations Act, Cap 466, through a Gazette notice, or legal notice number 14 on 21st January 2022, giving it its mandate to strengthen and promote public health functions by providing a centralized platform for the management and coordinations of key activities in prevention, early detection, and management of public health emergencies and events of concern. Next, please. So these are the focus areas that our NPHI looks at. Under surveillance, we do disease surveillance, we do food safety surveillance, antimicrobial resistance, zoonotic diseases, neglected tropical diseases, vector-borne diseases, and of course, when you talk about disease surveillance, we're also looking at points of entry. We also have the mandate of emergency preparedness and response. This is not just in terms of disease, as disease outbreaks or pandemics, but also disasters, for example, public health events that result from floods and humanitarian crises. We are also mandated to carry out public health research and innovation to guide decision-making and, of course, policy development. We are tasked with detection, and under detection, therefore, we are in charge of laboratory services across various levels from community to the national level. And then to prepare for such capacities, we have the workforce development as also part of our mandate. Next slide, please. So the milestones that we have been able to achieve, like most countries, the Kenya National Public Health Institute started as a unit within the Department of Preventive and Promoting Services within the Ministry of Health. That was done in 2011, and this was around the time after Ebola was a big discussion. But it did not become a state corporation or properly legislated until January 2022. The same year we appointed the board of directors, and then in November the same year we also started an operationalization work plan, which was funded by the World Bank. Then in 2024, the government then gave us the first funds, and we were able to develop governance structures. And we set up a transition task force, so we were able to transition functions from the ministry and previous areas where they were to the NPHI. Last year, March, we were able to transition the staff from the ministry who were carrying out these functions of surveillance and the function I mentioned above to the institute so that they can all be under one roof. And the cabinet secretary, who in many countries called the minister, launched the institute in May 8th. Next slide. So efforts towards strengthening emergency preparedness, we have, of course, the coordination structures. We have the National Action Plan for Health Security. We have the decision-making tree. This one guides the health workers from community all the way to the national level in making decisions during an emergency. What should you do? Who do you hand over to next? For information sharing, as you heard from our previous speaker, we have the risk communication and community engagement toolkit, which we have prepared messages to share in line with the risk calendars. We also have disease fact sheets, a monitoring and evaluation framework with proper indicators, and we have also established social intelligence, community engagement, and migration health divisions to support surveillance at the community level and also understands how the communities understand health information. Next slide. So the lessons we have learned, of course, is that legislative frameworks and policies are important to anchor national public health agencies for strong APR systems. We also need strong coordination structures to improve response, speed, and outbreak impact. Preparedness is not optional. It is a core national resilience function. The opportunities we have, of course, is strong partner ecosystems and regional initiatives like the Health Emergency Preparedness and Response and Resilient Project, which enhances cross-border collaborations. Of course, we have main challenges. We have lack of emergency fund for quick response. We also have insufficient advocacy for the role of preparedness. We are stuck with the panic neglect cycle in which whenever there's an outbreak, if you remember COVID, there's a lot of money that is provided to support the emergency response diagnosis. But once that is over, we all forget. It's the neglect cycle until the next time when we have an emergency. As a new institute, we believe this was a very good idea to establish, for WHO and IANPHI to come up with this document that is going to guide institutions on where to start and how to prioritize their mandate, depending on what their realities will be. So I want to say thank you for this opportunity and have a blessed evening.
Great. Oh, it's fine. Thank you. Thank you, Dr. Kimenya. And I do want to draw everybody's attention to the fact that you're giving up your valuable time while you're standing up I believe the world's most recent National Public Health Institute. And as you showed, that's a lot of work and a long road. Two things I wanted to highlight that you reminded us of is when we talk about we talk about public health emergencies, we are not just talking about the response, we are talking about the preparedness and having to make sure that we have an equal balance of the two. And then we're not just talking about infectious diseases, which is something that's critical to the work that we do, but a lot of these institutes also have the mandate for humanitarian response. And I think we are all very aware that the humanitarian and infectious disease emergencies are globally more frequent, they are more complex, and they're more protracted. And so just to have a thought, give a little thought to our colleagues from these National Public Health Institutes and the complexity of what they're dealing with every day. And with that, I'm very happy to introduce our next speaker. Dr. Johanna Hannefeld heads the Center for International Health Protection at the Robert Koch Institute, which many of you in the room know. It is Germany's National Public Health Institute, and Johanna is also RKI's acting vice president. She's also an honorary professor of global health policy at the London School of Hygiene and Tropical Medicine and a good friend of the Hub, so we're happy to have you.
Yeah, thank you, Sarah, for the invitation and the introduction. And first of all, congratulations to Kenya. This is wonderful, the establishment. But I also wanted to say thank you to Geoffrey and to Neil and Sarah for the work together, and to Chico. I don't know whether he's still here, but really congratulations on the framework, and it is here. I'm happy to hold it up again. For me, the process really started in March 2023 when WHO convened the first, what I think was the first meeting of sort of leaders of national public health agencies in Geneva. And at that time, the world was more peaceful and much more under the influence of the pandemic, of the recent pandemic. And WHO had recognized the work, and I think Chico situated that very nicely. So I'm proud to have gone a little bit with you on this path, and much has been said about the different frameworks. What I will provide here is a view from one National Public Health Institute, the Robert Koch Institute, and I'm delighted to say there are actually many colleagues from the RKI here in the room in Berlin. We are lucky to be a foundational partner of the Hub. And then I will offer some reflections from my perspective. And RKI, as a comparatively established National Public Health Institute, also has quite a strong mandate for global work. And I'll talk a little bit about that and those connections. But first, let me briefly introduce it. So we are Germany's National Public Health Institute, with a mandate to protect and improve the health of the population. We have many tasks, but I'll summarize them in three. The first is to collect data for surveillance and analysis of infectious diseases, biological hazards, and non-communicable diseases. So Sarah mentioned the difference in mandates the national public health agencies or institutes have. We have a mandate also for the non-communicable diseases. We then develop policy and medical expert guidelines and recommendations for preventive strategies. And this speaks to the global work that I'll explore a bit more, support partner countries with improving preparedness for disease outbreaks and health crises. And we do this through evidence-based research or data for decision-making, and offering independent advice to policymakers or public health services in Germany, the public health service. And I put this slide in here because I wanted to show you, and I think that's important, has been mentioned, is not one size fits all for what's in your National Public Health Institute. So in Germany, indeed, there are several institutes within the purvey of the Ministry of Health, and they have different responsibilities. So there's us. I don't know, I can't point, but anyway, you can see us. And then there's other public health institutes who deal with vaccines, with the licensing of medicines, but also with health communication. And the capabilities that are outlined here for national public health agencies are split across these 4 different agencies in this country. So just to say, just to reiterate, I think, and Geoffrey set that out very nicely, that it's not all the capacities that are set out there, 12 here, that you need to fit into one institution. I think the institutional setup varies across countries. I'll say a little bit more. This is always a slide that really enthuses people when you put this up. So we have 7 scientific departments where, just to give you a sense of the size, 1,500 employees. We're very proud that we've got colleagues from more than 50 nationalities working at national level. across many disciplines. And that's a point I also wanted to stress. So these different capabilities mean you need a very interdisciplinary workforce. And then we have a very strong international mandate. We're very proud to host 6 WHO collaborating centers and also the IANPHI Secretariat here in Berlin. What I haven't put on the slide is just going to say, we are actually the world's oldest national public health institute, I think. So, Nilas, so it's delightful to be here with the Kenyans, who are, if they are the youngest indeed. But we take this responsibility seriously. So our international mandate means, and our age, combined means that we get many, many requests by our sister and brother agencies to help establish. And I haven't put the figure on the slide because it's always like, how do you count this? But we have received more than 70 requests to help establish national public health agencies since the pandemic began. So this is just to give you an indication how big the pressure is and how timely it is that IANPHI and WHO have come up with this guidance to countries. So Chikwe's experience, I think, was replicated in many countries around the world, and it's wonderful to see this. And we have a relatively strong, as a national public health institute, we have a relatively strong mandate for the international work, and I'll talk about that a little bit. But I would be remiss to talk about that here without saying that a lot of this work we actually do in partnership with the WHO. So we have a partnership with the hub through 7 projects where we work on different facets of public health capacities. We work on antimicrobial resistance. We work on strengthening biosecurity. We also work on public health intelligence and genomic surveillance. And it's against this backdrop, really, that I want to offer some reflections in light of this framework. So the institutional architecture at the country level is not the same everywhere. So you've seen the 4 boxes I had on my slide. That's for Germany. There's also other agencies that belong to other ministries and so on. So the institutional architecture is going to be very, very varied. But the core functions needed in an emergency are relatively clear. Right? So, and I think we've heard that, I think also from Kenya, what we saw, very sort of clear functions, and you somehow need to have them described so that in a public health response, you can bring them together. And that, to me, is the value of having common definitions around this. So it's not just, or it is in addition to what Chikwe outlined and what Neil outlined and what we heard from Kenya, it is the ability to have a shared language around these functions so that we can come together, that we can act on this common architecture along defined functions. And I think the other thing that's very, very evident is no matter how many global framings you put and how the world changes, in a crisis, the first responders are at national level. Right? So the crisis likely starts in the community, but the first responders are at the local level and then at the national level. But you need these national levels to be integrated regionally and globally. And that's really why this architecture we're seeing around the national public health institutes is so important. That's why it's so important that WHO now engages more formally with it. That's why IANPHI has become such a valued network. And the regional CDCs, and we're lucky we've got a strong one in our region, ECDC, but Africa CDC obviously has become a strong regional player, and we're seeing one developed in the ASEAN region. They're really important as a network. So national public health institutes are national actors, but they are globally connected and networked. And there's a lot of talk now around the global health architecture and what's going to happen and how is all of that going to reform. And I'm not going to give you a summary of all the different essays that have been written and published and so on, but everyone agrees is that it's the national level that needs to be strengthened. And it's precisely the capacities that have been set out here. So I think that is really where this comes together and why these frameworks are so important. And it needs to be strengthened really as part of all health emergency capacities, but also crisis resilience. There are 2 big things, I think, as we take this agenda forward. One is to ensure the connection to communities. Communities are not public institutions, and it's tricky. And I would say in the past, maybe collectively we haven't quite done as well. And the second is point which is tricky to address is that Sarah mentioned it, and I tried to say it at the beginning, the world is a lot less peaceful now. So in many ways, it's very hard to operate in the conflict that many of our agencies or our sister agencies now work in. So it's this aspect of peace that's really important too. So those are my my reflections roughly. We've been delighted to walk alongside IANPHI and the WHO on this path, and it's wonderful to see all the different experiences from around the world as this continues to grow. Thank you.
Great, thanks so much, Johanna. I'd like to take credit for having put the newest National Public Health Agency and the oldest one together, but I think that it was just fortuitous. But it's very exciting, actually, because I think what it highlights is regardless of longevity, all countries and all institutions are grappling with a lot of the same questions. There was not one country that put their hand up and said, well, no, we've already mastered this. We've got this. We don't need any more information. We don't need to work together. You know, off we go. So I think that is really important. And I think reframing it back again to it's all about national capacities. And I think that lends really well into our final speaker, who I'm very excited to introduce. It's going to talk about how you build national capacity, but from a regional perspective. And so we're happy to have Dr. Lisa Indar with us. She's a public health leader with more than 20 years of regional and international experience, and she is the executive director of the Caribbean Public Health Agency, or CARPHA. She previously served as its director of surveillance, disease prevention, and control, and she's also another good friend of the Hub. So Lisa, welcome.
Thank you very, very much. I see that my time zone, but you know, a shout out to all my friends at the Hub and to Neil and others. Really glad to be here. Straight on to the slide. Next slide. Okay, and so it's always good to just talk a bit about CARPHA. I mean, who we are. So CARPHA, you know, is the regional public health agency. We are mandated by heads of government, the CARICOM governments, to serve the region, and we serve the 26 members. And the way we operate is that regional coordination approach. We were embedded in regional coordination and regional communities. So everything we do, it's all about regional public health and providing regional public good. Next slide. And this is who we serve here. And you would see these 26 countries and how we serve the region. Next slide. So going straight into surveillance and emergency and response, we do have that mandate for surveillance and response and to lead public health surveillance and to lead emergencies. And this comes, and these are just different documents that shows that, you know, how we carry out that mandate. Next slide. And this perhaps to me is the most important slide because it's all about context. And Neil spoke about phoning a friend, and the previous speaker spoke about context. And, you know, when we talk about the Caribbean, it's really important to look at context and how we do emergency and response given our unique context. And we are unique. We are 26 diverse small island developing states. But these developing states are just so porous, but so interconnected with porous borders. And they have varying health surveillance systems and capacities. And then we have high dependence on tourism, as well as high vulnerability to natural disasters and climate change. So an outbreak in one member state is almost going to be an outbreak in the region because all of these characteristics increases the risk of disease spread and increases the rapid risk of disease spread across the countries. So this unique exposure and vulnerability to this wide range of public health threats and all these unique characteristics requires Caribbean tailored interventions because some of the traditional surveillance methods may not always work with these small island developing states of varying capacity. So this is where CARPHA comes in and looks at what's happening internationally and works with our international partners, but then develop Caribbean tailored interventions to aptly suit the region. And all of this is supported, you know, developing robust, integrated, regional integrated real-time surveillance systems with laboratory systems and workforce capacity strengthened, but supported by strong multisectoral partnerships. Next slide. So going straight into how we do emergency and response, though I know this is busy, but I'll summarize it. You know, CAFA, in terms of when we have to respond, we respond to all types of emergencies, whether it be a communicable disease, infectious disease threat, and natural disasters. You know, we were just responding to Melissa, whether it be flooding and whether it chemical or radiological. And what type of work we do? We provide technical support. We provide a lot of capacity building, a range of different capacity building. We provide supplies, and we provide response. In terms of response, we would, you know, at CAFA, we have an IMT, ER Incident Management Team. We will activate, and that helps us to respond faster. And we may, if we are called upon, we will deploy, and we could deploy under different mechanisms. If it's a public health emergency, CAFA leads in that. If it's a disaster, we would work with our partners, SEDEMA, Caribbean and Disaster Management Agency. And we just concluded GONE training, so we could also deploy by GONE. But our work is very specific in terms of, you know, looking at our unique work and how we are going to help countries. And when we go to countries, we are teaching them and executing this early warning systems we have developed, timeliness metrics in terms of, you know, instead of an amendment to 7717, but in a small island development state, you need to identify a public health threat, you know, within 1 day, because some islands may be wiped out. And we have tailored specific simulation exercises. And then early warning, all of our surveillance systems have been updated where you have an alert mechanism, so they become early warning. Next slide. So this really is our package that we are working at country level. And the idea is that every time we go to any country, this is the package, all these different suite of surveillance systems together with simulation exercises, timeliness metrics, and infodemic monitoring, and work with our partners to deliver, whether it be, you know, PAHO, WHO, and so on, so that it's a harmonized set of execution. And regionally, this is what we are also promoting. And, you know, anything we do, we have to have the governance with it. So we would have presented it to our ministers of health, and it was approved last year. So this is a trajectory, how we go forward, and implementing all that we do know from WHO and others, but infusing it into this mechanism. Next slide. And so our real-time early warning systems is what we're working on now. All our surveillance, whether it be syndromic, vector-borne, foodborne, travelers' health, and others, we are working in towards developing this one platform, a real-time early warning system, one platform surveillance system that may have many different components. Some may be on the HIS, some may be on something else. But the idea is to have interoperable system that are all digital with alerts, so that you can have near-time or near real-time analytics for timely detection, verification, and response, which is what the unique nature of the Caribbean region demands. Next slide. So, not to bring into more, but we are progressing. We have a range of different surveillance systems, and we have different programs. Our laboratory, health information unit, we have emergency and response, travelers' health, vector-borne, foodborne, and antimicrobial resistance, in which incidentally we are launching today, our environmental health department and others. We're taking all of that and coming up with outputs, whether depending on the system, but making these outputs that are digital, as well as having an alert mechanism. And this will then be available to countries so they can easily detect a public health threat and respond. Next slide. And all of this is supported by the programs and the partners. The partners, we cannot overemphasize the work of our partners and mechanisms. We are the chair of the Regional Coordinating Mechanism for Health Security, which is a body consistent of countries and all our major agencies, CDC, PAHU, WHO, and others, that comes together when we have a situation, a regional or international outbreak. It really helps us in terms of coordination and how we can best coordinate. And actually, we activated the Regional Health Security Mechanism for COVID that helps us got through coordination with the many agencies. And we all of this to do this through an integrated approach. Next slide. I see my time is done, and I think I'm nearly finished. We have many novel outputs, the real-time early warning systems that I spoke about, the simulation exercise, timeliness metrics, novel mass gathering surveillance systems that is working, with countries, confidential traveler health systems that detects and you can respond very quickly. Our Caribbean first integrated One Health platform, leading, having a GOAN partnership for training. Next slide. Launching and having an integrated antimicrobial program and expanding our laboratory testing capacity to clinical testing and antimicrobial testing to all 3 of our lab hubs. It means that all our Caribbean countries have faster access to testing and providing other supplies like MolBio and other workstations. And I think this is my last slide. And most of all, that what is in red, the partnerships with the UK and GOAN and IANPHI and others and WHO really helps when we work together to deliver emergency and response in a harmonized way, but in a timely manner for the Caribbean region. Thank you so much.
Great. Thanks so much, Lisa. Maybe a couple of things that I really took away, highlighting the importance of having very sensitive alert systems and alert mechanisms that are interconnected and allow for immediate response, whether it's to an outbreak or a natural disaster. But maybe bringing you back to the first words that you talked about, that you regionally are working with 26 small, diverse, but highly interconnected countries. And for anybody here who works with one government every day, imagine working across 26 governments and bringing and interconnecting this work together. And that's really what CARPHA's job is to work for every day. So just to really acknowledge that, it's incredibly important. Not only do you have to be technical specialists, but you have to be very good diplomats. So to recognize that. Now we're going to turn to our panel. I'll ask our speakers to come back up to the stage. And I'm happy to hand over our panel discussion to our colleague, Katie Smallwood, who is the Public Health Surveillance Unit Head here in the Hub. Please come up. Please rise.
Thanks, everybody. And I'd just like to thank all of our speakers for, first of all, very, very diverse presentations. But maybe in the conversation, and we have about 15 minutes, I think we can knit some of these interventions together. I was really struck by some of the first comments today. Stefan, you talked about NPHAs as where it all comes together. And then Chikwe said, well, during the pandemic, we had nothing that laid out what that all is and how that all has to come together. We also spoke quite a lot about the common language and the shared definitions that this framework brings, and how that can then be used to unlock at the global level the capabilities that exist across all of the countries around the world, and the role that IANPHI might have within that. So going from some of these conversations and hearing from the public health agencies themselves, both the very young, the very old, the ones that cover 26 countries in one, I wanted to start this conversation by really asking the question, how in practice might this framework work across agencies that have 134 years between them, but also in an agency potentially that is dealing with 26 countries with very different capabilities in themselves. And also in a context where we have a lot of different frameworks at play. We heard from Kenya the linkage to the National Action Plan for Health Security. So perhaps first I can ask Geoffrey, how can this framework be implemented at the country level? And then I'd invite our speakers to think a little bit about their contexts and how that framework might help in the very young and the very old and the very diverse.
Thanks very much, Katie, for the question. To your first one of how do these frameworks relate with each other, this has been developed to be very complementary and aligned to all the additional frameworks, normative guidance that exists. How can it be used? As I highlighted in the slide, the last or second last slide, wherever you are on this journey, and we acknowledge, as you rightly said, there's very many across the entire continuum of the development process. Look at where you are, look at the 12 capabilities. Which of these do I have? Which of these don't I have? Do I need them? And how matured are these? And therefore, how can I build on the ones that I have to be able to strengthen them for better preparedness and response?
Thanks a lot. I'm wondering whether Kamene or Nyahana, and I hope everyone doesn't mind me calling you by your first names in this conversation, if you have any reflections as a ancient agency and in the new kid on the block.
Kids go first.
Yeah, thank you. Yes, I don't mind being called Kamene. Actually, that's my favorite. Yes, I'm actually first happy. We are just 1 year post our launch, and this is a very crucial time for us to grow. I say these two frameworks have come at a good time. One, we are setting up the institution, and the IANPHI document is very good at guiding the institutional establishment. And then for the WHO, what WHO has introduced is the technical content that we as an institution need to ensure that we are looking into. One of the things that, as my previous speaker said, is looking at our environment. As Kenya, of course, emergency preparedness surveillance have always been done, but it's how is it done and how can we align? So adoption of this will be customized to our country experience. So we look at the two documents and customize them to make sure that we usually say the word, we Kenyanize them and domesticate that so that we can be able to utilize them based on our current circumstances. Thank you.
Okay, so I think one of the things is even if you're old, you need to continue to innovate, right? And the context constantly changes. And it's very, very good that there's a normative guidance document by the World Health Organization that sets out the core capabilities of national public health institutes. And it's been incredibly useful to have the FOs defined by IANPHI for political processes, to communicate to policymakers at national level about our core functions, to have a reference to hold ourselves accountable against, and to continue to innovate. So I think that's important for everyone, no matter where you are on your maturity journey or however you want to phrase it, right? So it's good. It is good to have that. And the second point, I think I mentioned this, is really to have a common understanding of those functions, especially because they tend to be spread across a different institutional architecture at country level. And that is so important because while the first responders are at national level, very few of our crises are just confined to one country. So there are examples of outbreaks and crises where we deal with just a national crisis, but even if that is the case, we like to go and exchange with our brothers and sisters about how they have dealt with similar outbreaks and crises. And you do need to have that common definition to be able, or that enables this language and sharing, especially given the differences in institutional setup.
Thanks a lot. Lisa, I was just wondering if you wanted to come in on how a single framework like this might be applied in your setting for a regional public health agency, and how those capabilities might be distributed across the islands.
Yeah, thanks. And my last slide, but because I've went out over time, really speaks about that. And it's important to have frameworks. And this framework, what we have done with this, we've taken this framework and tailored it to serve the region. When you're dealing with 26 diverse states, one size doesn't fit all. So you have to really apply to context. We have countries that, can just perhaps do diagnostics, but, they don't have all the other subsets of an enhanced surveillance system. So it's all about coordinating, and as a regional body, we fill the gaps. So we learn from what the international framework, take it, tailor, develop Caribbean tailored interventions, and then work with the countries, hold their hands so that we can build that capacity to get it done.
So, Neil, as someone who's worked with National Public Health Institutes through IANPHI for a very long time, what might realistic progress look like? What might we expect to see on a yearly basis, year in, year out, when we're building these quite complex institutions and thinking about these capabilities? And what might a very new institute like Kenya's seek to achieve in the first few years of its establishment? So maybe I can turn to you, Neil, and then back to you, Kamene, to reflect a little bit on what you seek to achieve.
One of the nice things about population growth is there are always new babies that come along. So I do want to acknowledge that the Public Health Institute of Zimbabwe has its new institute that was only formed in November 2025. So there is a maturity model. So with our new baby is Zimbabwe. But for all organisations, as Johanna's just said, the framework should serve as a mirror, and we can see our own development when we look, and that goes for old institutions. We might see the wrinkles beginning to develop, and there are things that we can do to enhance our capabilities and to build our capabilities. So each year, every national public health institution should look at where it is, compare where it is against the framework of what is possible, should look at case studies and examples of what others have achieved, but not necessarily assume that what they have got is inferior or that they're on a process of development. So the idea is that those people within the institutions who have an understanding of what is possible in their country with the resources that they have, they then identify what they think they realistically can achieve. So for me, the great utility of this and the process that needs to go on is that regular reflection on what we've achieved and what we want to achieve going forward. So and only in that way can we mature gradually by building upon an understanding of where we are and looking at where we aspire to be. So the stage development tool that IANPHI has encourages that process of reflection, identification of competencies currently, and aspiration and looking forward. So it's a process that every NPHI, no matter how old and well established it is, can go through, and tools like this help that process.
Kamene, what is some of the achievements that Kenya's NPHI is looking for in the next couple of years?
Thank you. I think the first thing that we have to look at is the Kenyan health system is devolved. In other words, we have service delivery at the subnational level, and we also have the role of the national level, which is policy, and then the NPHI comes in to lead the operational matters related to emergency preparedness and response. So one of the things that we have to ensure is that our systems from the community are now functional as a priority. Because if once we have that, then once the system is oiled, I like to say, then we are sure that in case of an emergency, then that system can operate in spite of the available resources at that time. The second thing that we want to ensure is that we have adequate such capacities for different counties that can handle county-specific, our subnational level is called county, that can handle county-specific challenges. What are the public health threats at that level or that county? And are they able to respond at the county level so that we can strengthen our foot soldiers to be able to respond? The idea is that within the low-lying fruits that do not require high resources are tackled within the first year, most likely within the second year. And then things like laboratory capacities that are cost intensive now can be planned over time. And then maybe in the next 5 years, especially now that we're having the different funding mechanisms that we are working on and partnerships, we'll have established those systems of detection. And now one of the things that I mentioned about the M&E framework is the 717 that we are also looking to ensure that we can monitor. We have already started to do our baseline assessments in around 11 counties, and hopefully we'll have finished doing our assessments in the different counties to see how well are they prepared to respond. And then we are able to monitor on an annual basis based on the outbreaks that we have experienced. How well are we able to reach the 717 metric? So yes, there's the institutional, and of course there'll be a number of technical areas that we'll be identifying as priority for the next few years. Thank you.
I'm going to come back to the issue of financing towards the end. But before I do, we had a couple of questions from the audience, and one of them dwelled on the community level and picked up on this point. Johanna brought it up and others too. So how should we better engage communities in a framework of this type? How to do it?
Just a quick response. I mean, I was in WHO in Geneva earlier this week, speaking to the community development sort of team there, and engaging with communities requires people who are in contact with them. And in most countries, the primary care system is the starting place. So when we think about emergency response, we shouldn't only think of the institutional capacity that's in our direct control. We need to think about all the functions of government and indeed the private sector that are in direct contact with communities and how we can support them. But we also need to consult with communities and understand the influences and things that are shaping their lives. So particularly in a context of huge misinformation and disinformation, we're not the only voice that reaches communities, and we need to understand and have access to the messages that are being received and to listen to the eyes and ears of communities in order to inform what goes on. So for national public health institutions, that does mean establishing a close connection, either through their primary care system or directly with people within communities, and listening to their voices and ensuring that those are reflected in the design and development of services.
Thanks. Yes, as Johanna earlier mentioned, every outbreak does start from the community, and therefore we need to have mechanisms, systems, infrastructure to be able to pick it up as and when it happens. Relating to this framework, we've dedicated 2 capabilities around how can we get the communities involved. In the public health surveillance and public health intelligence, we do highlight the role of having community-based surveillance systems in every governance mechanism, but also in another capability dedicated to risk communication and community engagement. These outline how best can a public health agency or institute or CDC or NIH can have that listening ear down to the community.
Great. We also heard the diversity of hazards and health threats, and the complexity of those is only increasing. And amongst the broad opportunity to actually transform the way we respond to emergencies, NPHAs are playing an increasingly important role. So one of the questions we had asked ourselves is, if there's one thing that your national public health or regional public health agency could do now that could change, transform the way we respond to emergencies, what would it be? Lisa, I see you smiling at that question. Perhaps I can put the spotlight on the Caribbean.
Yes, well, for us, it's all about timeliness. This is the trajectory CAFR is moving to. As I said in my presentation, we have developed regional integrated early warning systems, and it's all about being able to identify something quickly. We have taken the 717 and really amended it to suit the region. If you have an outbreak of, let's say, measles in our small communities, it's going to wipe out islands. When you have a hurricane, it destroys an entire island. So you really have to have early warning systems so that you can have rapid response. And I want to say almost instantly, we don't have the privilege in our small islands of, waiting. We have to respond, the same day or immediately, within 24 hours so that we can protect these small, fragile nations. So for me, the biggest thing is moving towards working with all our countries from, I want to say from community level to the highest level or top down we work with our chief medical officers. We do a lot of stakeholder interventions and say, this is how we can implement this, at the highest level and down to the community level, but moving towards, real-time early warning systems supported by real-time laboratory detection and, adequately trained workforce, and of course the partnerships to support that.
Thanks a lot. So maybe I will recap a little bit and end with a final question to the panel, and anyone's free to jump in before we close today's session. But we already heard that this framework offers a mirror to national public health agencies wherever they are in their level of maturity. It also offers a pathway through which incrementally or transformatively national public health agencies can improve selected or prioritized capabilities. There may be some quick wins that don't require huge amounts of resources, but when you have political leadership can move on earlier, like a well-oiled emergency response system. There may be much more expensive interventions that would take more time, like big laboratory infrastructures that need to be built. There's also an opportunity to engage at the very community level and put in place mechanisms to engage communities where they interact directly with the health system, so at the primary care level and across the board. And there's also clear potential to offer quite transformative interventions that can improve the timeliness of response. And when we talk about emergencies, time lost means people getting sicker and people losing their lives. So I think I come back to Kamene's point at the end of her presentation, which was, I think, alert today, alive tomorrow, something that we can take away with us, and that ability to respond. And my final question is, how can we sustain this a lot across time, in a period of fragmentation, in a period where politics is all about short-term goals, where there's a lot of change and financial constraints. So what must we do to ensure the longevity of these interventions?
Yeah, I'll go first. So I think it's a tough time. So I think how do we sustain this? We sustain this through partnership, right? We're here because we're all national public health institutes. We work together through IANPHI. We are in bilateral partnerships. We work together with the WHO, multilateral, bringing us together. I think at national level systems are crucially important, and they're under pressure to some extent, right? So the funding is shrinking, so we got to be clever collectively as a community of national public health agencies, but internationally connected. So maybe you don't need to build labs, maybe there's some labs in the university that can serve as your public health function. I was just thinking when you were saying that. So it is about using this framework in a way that is clever at a time when maybe there aren't more resources. And then I think collectively as a community to sustain the investment that is needed to keep public health systems going, we do need to make the argument that the resilience of our societies does depend on these functions, right? And that argument never goes away. And whether you're the oldest NPHA, you're the youngest, or you're just being born, or whatever. Not to overstress the metaphor, you always need to make that argument, every single day. So that's how we do it, and we do it together. Thank you.
I think, please go ahead and clap. Thank you so much for our presenters today and for the conversation. I'm going to close the panel and hand back over to Sarah for some closing remarks.
Great. Yes, thanks so much to exceptional speakers all around. So you have made my job extremely easy, because I'm not even going to try to summarize this, because what you've all said tonight has really kind of captured the essence of what we're talking about with how do we build emergency preparedness and response capacities, particularly with national public health agencies. I just want to really thank both our speakers, our partners, including IANPHI, and particularly our collaborators and member states, the countries that are really delivering this work. I can say from WHO's side that we are committed to helping countries and organizations to learn from each other, to take this work forward, and to build their own country and regional capacities to be better prepared for and to respond to public health events. Finally, I want to really thank our audience. It's always great to have an energetic, engaged audience. I'll bet our audience online is also energetic and engaged. I can feel it. And we really appreciate your interest and your support in making the world safer from public health threats. So for those with us tonight, we invite you to join us in a reception. For those online, hopefully we can see you in person sometime. So thank you very much. Great. Photo.